Welcome to Impact OC, the only program showcasing the people and organizations shaping Orange County. With your host, Don Camber.
Hello, live from the OC Talk Radio studios at UCI's Beale Applied Innovation Center. I'm OC Talk Radio Public Affairs Director Don Camber with another great guest who is making a significant impact in our community. Today, I welcome Dr. Brandon Richland, the founder of Richland MD and Richland Aesthetics, based in Newport Beach. Dr. Richland is a board-certified plastic surgeon renowned for his expertise in full-body natural makeovers. Today, we're diving into an important topic, breast reconstruction. Breast cancer is the second most common cancer among women and a leading cause of cancer-related deaths in the U.S. However, our discussion will extend beyond cancer as we will explore breast revision surgeries for women facing complications from breast implants, such as capsular contracture, hardness, pain, and deformity issues that can arise even in the absence of breast cancer. Well, thank you, Dr. Richland, for joining us on Impact OC.
Well, thank you, Don. Appreciate you having me on this talk radio, and appreciate you allowing me to raise awareness for this issue.
Dr. Richland, can you share how your work in breast reconstruction and revisionary surgeries helps women not only regain their physical appearance, but also rebuild their confidence and quality of life?
Yeah, so for real fast, what we'll do is we'll separate breast reconstruction from the term breast augmentation. So breast reconstruction is for women who've undergone breast cancer and they've generally had a portion or all of their breast removed, versus breast augmentation is generally enlarging the size of the breast for cosmetic issues. So first we'll start with the breast reconstruction issue. And when a patient's diagnosed with breast cancer, there's many treatments available. Generally, they center around surgery, whether it's removing a portion or the entirety of the breast. When that's done, obviously these treatments are life-saving, but they can leave the patient deformed with sort of a loss of sense of self. And that's where I come in performing the reconstruction.
Now, does it happen on the same day, around the same time? If a person has cancer-related breast surgery, then they go to you to get the plastic surgery to make it look good, or do they have to do it on a different day?
So the old traditional way was to do what's called delayed reconstruction. And that means the breast cancer is removed initially by the breast surgeon, and then the reconstruction is performed later, sometimes 3, 6, 12 months later. The newer technique is generally to do immediate reconstruction, which is done at the time of the mastectomy. And so that's what I do for probably 90+% of my patients right now, is doing the reconstruction on the initial surgery when the breast, the portion of the breast is removed.
So is the initial surgery for the cancer done in a different room and then they go to you, or do you walk in? How does that work?
So it's done in the same operating room, in the same surgery. So the breast surgeon starts first. Their procedure maybe takes an hour, maybe a little bit longer. And then once that portion of the breast has been removed, then I'll come in, the patient's still asleep in the same operating room, and then I'll perform the reconstruction.
Talk about the factors involved for the reconstruction.
So when we're considering reconstruction for a patient, it's a very personal decision. So I see my job as the surgeon is to inform the patient of the options available so they can make the best decision for them at that time. In general, though, patients who don't have significant medical comorbidities or patients with early stage breast cancer diagnosis make for better breast reconstruction patients. I think my headphone just went out here.
So do you make the breast look as natural as possible? Is that the goal on your end? And of course, that's what the patient would want.
My goal is to essentially make the breast make the breast look as natural as possible. And that sort of, it gets a little tricky, right? It depends on what stage of the breast cancer is, whether they can have immediate or delayed, and then also if we're able to save the nipple. Saving the nipple is done with a discussion between myself, the reconstructive surgeon, and the breast surgeon, because obviously our number one goal is to make sure that the patient beats the breast cancer. And so sometimes the nipple may need to be removed, and that then requires further reconstruction afterwards.
So, and that's what you'll determine right then and there, or that's what'll have to happen.
Generally, that's determined prior to surgery, but the final decision is made intraoperatively.
And what about the effects of radiation or chemotherapy on what you do?
Yeah, so both of those treatments, again, are life-saving and they're necessary. So I always advocate for those treatments if either the radiation oncologist or the oncologist believes that the patient would be a good candidate and benefit from those treatments. But it does make the reconstruction a little bit more difficult. Radiation in particular can cause issues like capsular contracture, which is hardness and scarring around the breast implant. And there's a higher risk of complications with radiation and chemotherapy as well. Reconstruction can still be done, but it just needs to be done in sometimes a more controlled, safe manner, and sometimes delaying the reconstruction because of those treatments.
Now, you told me before we came to air that there's a big change in what has occurred over the years with reconstruction in terms of the scar.
Yeah, absolutely. And that's correct. And just as technology evolves, surgical technique evolves as well. So the traditional way was to have a big scar sort of across the chest, about maybe 15 centimeters along, this large horizontal scar. The breast tissue would be removed, and then the reconstruction would be delayed, 3, 6, maybe 12 months. Now the newer way is, if possible, we try to save the nipple and areola, which allows the reconstruction to look more natural. Now we also try to go directly to the implant. So at the time of surgery, I'll try and actually put in a breast implant if possible. And then also the incision is a lot smaller. So now we can do it just through maybe a 3 or 4 centimeter incision right around the areola. So it's really well hidden. And these scars are almost the same size as breast augmentation.
When we talk about implants, what materials are you using?
So there's two main choices. So there's a silicone and a saline choice. Most women now opt to go for the silicone choice because it looks a little bit more natural and feels more natural, especially in breast reconstruction patients who have very thin skin remaining. Some patients don't feel comfortable with that though, and they do elect to go for saline implants. The saline implants have a silicone shell, but are actually filled with saline. So it's almost more mimics like a water balloon type of look and feel. So again, it's a personal decision, and I discuss both with the patients.
But what lasts longer?
It depends. On general, the silicone implants will last a little bit longer as far as rupture and things like that. If a silicone implant ruptures, you may not know right away because the silicone stays there, especially with the newer age gummy bear implants. You can almost cut those implants and the silicone actually stays right there, just as if you're cutting a gummy bear, which is pretty neat. The saline implants, if those rupture, imagine a ruptured water balloon. That water is going to actually go into the tissues and be absorbed, and then you're just going to urinate out the water, usually within about 24 hours.
Now, do you often go from breast reconstruction to breast augmentation because the person's having the operation anyway?
We can. And so what happens sometimes is if a patient has breast cancer on one breast, we perform the breast reconstruction on one side. And then sometimes they'll come back and actually get a breast augmentation with or without a breast lift on the other side. Now, because that second side hadn't had breast cancer, we sort of considered a breast augmentation, but it's really being done for reconstructive purposes, right? We're trying to get better matching symmetry. And the really neat thing is that because the patient did have breast cancer, insurances actually pay for that operation.
And what have you seen in terms of the lives you've changed with your work?
It's very meaningful. And this is why I love to do breast reconstruction, because it's helping that patient complete their journey in beating breast cancer. And, beating the breast cancer is always the number one goal for everyone who's involved. But then afterwards, I really want that patient to sort of restore that sense of self and feel like they've completed their journey. And that's why I feel like breast reconstruction is so important.
So what do you hear from patients before they go into the operation in terms of their fears?
It varies. So some patients are just sort of gung ho. They're like, just let's do this thing, right? Other patients, they're a little bit more fearful, like you said, right? They're worried of the unknown. They're worried of anesthesia. They're worried about the breast cancer. worried about, maybe the breast implants. And so in those patients, we obviously, I spend more time talking with them and discussing any concerns that they may have.
Can they lead a normal life, do regular activities after they've had this operation?
Yeah, absolutely. And that's my goal is I want all of my patients to get back to their normal life. I want them to, feel good about themselves, to look good, to be able to wear a bra, to be able to wear clothing, to go shopping, to do all of these things that they once did before. Yeah, so that's my goal.
Is there anything they need to do in terms of maintaining what they got?
As far as maintaining the results
Yes.
there's nothing in particular that would be necessary once the reconstruction's been completed and they're out of the early post-operative period. Generally, I'll have patients do something called breast implant massage, which is just moving the implant around a couple times a day to keep that pocket open. But other than that, there's not really anything that's necessary once they've completed the recovery.
What's the age range of women you assist?
It's a pretty large age range. Most patients for breast reconstruction are somewhere in the 30s to up to 70s or even 80 plus years old, just depending on the diagnosis and at what point they are in their life.
Now we can go to breast augmentation, which is what people want to do to enhance their breasts.
Absolutely. And that's a fairly common procedure in the United States and Orange County as well. So that's another common procedure I perform.
And what age do people start doing that?
It varies. I'd say most patients are in their 20s to probably 50s for coming in. Most common's probably somewhere in their 30s or 40s.
And why do they choose to do so?
It's a variety of reasons. Some patients have trouble fitting into bras. Some patients are born with lack of breast tissue or even have breast asymmetry. So it sort of varies by patient.
And when it comes to figuring out the best materials to use, is it silicone and saline that you would use for breast augmentation?
Correct. So the implants are similar between breast reconstruction and breast augmentation. It just sort of depends on the use and for what purpose you're using those. So again, it would be silicone and saline, with most patients opting for silicone.
How long do these operations take?
A breast augmentation is pretty quick. It's generally just about under an hour of surgical operative time.
What about recovery?
Recovery isn't too bad. It's usually about a week of recovery. And then usually by about 2 to 3 weeks, patients are, back to the gym and back to their daily life. Nothing too strenuous, of course, at that point. But
what about pain? Be honest.
Well, it doesn't hurt me at all to do the surgeries.
I'm not talking about you.
Oh, okay.
But for them.
No, of course. So patients do very well. Breast surgeries are actually not, in general, not too painful. They're more just really sore afterwards, almost as if that patient had done, 100 or 1,000 push-ups the day before. They're really sore. I also do a pretty good amount of numbing medication, and I think that can help with the recovery as well.
So kind of give us an overview of the different kinds of technology that has changed for you to do your operation.
So as far as the implants or sort of the technology
in general, because it has changed.
Yeah, absolutely. One of the biggest advances in breast surgery has been the improvement in the technology and quality of the breast implants. And that's especially significant in the silicone implants, where right now we're in the 5th generation of silicone implants. And we call these the gummy bear implants. So like I mentioned before, these implants are very cohesive. And what that means is the silicone will all stay sort of together in case there was a rupture or the implant got cut or something like that. And that really helps out the patient because we don't want that silicone leaking everywhere. And it also helps out the surgeon. So if there was a rupture, when I go into the breast pocket, it's not like a bunch of silicone. I can just sort of scoop that implant out and clean everything out, and it's a lot simpler of an operation.
Now, when it comes to mammography, they can go and get their breast checked like normal, and if there's cancer, it would be seen?
Yeah, absolutely. So in Orange County, all the radiologists are very trained in, analyzing breasts that with or without an implant. And it's very clear on the mammogram what is breast tissue and what's implant. Sometimes they'll do an additional view or two to be able to visualize different parts of the breast if there's an implant, but they can screen the breast, patients who've had breast augmentation, they don't have any issues with mammograms.
I dare ask if you've ever done breast augmentation and noticed breast cancer.
I have had patients who I've sent for screening testing before breast surgery who then have found a lump. I have not found breast cancer during a breast augmentation operation, thankfully. But that's why I do these screening tests prior to surgery, because if I'm going to be operating on a body part, I want to know that it's going to be safe for the patient and that we're cancer free. And it was almost like a blessing in disguise to find something that was so small so early that the patient probably wouldn't have known about otherwise.
Let's talk about the different tests that are available.
So there's several tests. The most common screening test for breast cancer would be a mammogram. In patients who are younger and have thicker breast tissue, sometimes an ultrasound is performed. If there's anything that's not certain with those two tests, they can also get an MRI. Once there is, we call it a lesion or some concerning finding, generally a biopsy is performed to establish the diagnosis.
And then once the diagnosis is confirmed, then they might get something simple as a lumpectomy.
Correct. So going back to breast reconstruction, there's a few different surgical ways to treat that breast cancer. If the breast cancer is very early stage and it's very small, something can be done, a lumpectomy, which is basically just removing that breast cancer and a small layer of tissue around that breast cancer spot. The alternative treatment is a mastectomy, which is removing all of the breast tissue in a breast. The advantage of a lumpectomy is, the defect is smaller, it's a smaller operation, but the disadvantage is it requires radiation afterwards. And so they have to undergo radiation, and sometimes, the effects of radiation can be damaging to the tissues.
Will you get a chance to reconstruct it at that point? Or if they're going to have radiation, you can't?
I can, and it depends. So generally, I try to set the patient up for success as best as possible prior to the radiation. Reconstruction can be done with the event of radiation, and it commonly is done. If the patient's having a lumpectomy and that they need a radiation, if they have large breast, I can almost turn that lumpectomy into a breast reduction sort of surgery. So let's say the patient had E or F or G size breasts and they wanted to get them reduced anyway. If the lumpectomy is in the correct spot, we can do the lumpectomy. I can then perform a breast reduction, and then they're almost getting a 2-for-1 and handling that issue at the same time. If
they choose to go for a mastectomy on both breasts because they don't want to get cancer, and is it true that if you get rid of the breast cancer can't come back?
The risk of breast cancer is exceedingly low after a mastectomy, especially a prophylactic mastectomy, meaning they actually don't have breast cancer. So let's say one breast had cancer and you're performing mastectomy. Let's say the other breast did not have cancer. That would be considered a prophylactic mastectomy because they didn't have cancer in that certain breast. The risk is exceedingly low to get breast cancer in a breast once the mastectomy has been performed.
Will you then reconstruct so they get 2 breasts? Can you do that? And do you do it?
Correct. Yes. So there's 2 ways to go about it. One is we could reconstruct one breast at a time. The other way is to reconstruct both breasts at the same time at the same surgery. It just depends on a variety of patient factors, how the tissue quality looks at the time of surgery, things like that.
But you're literally reconstructing breasts.
Correct. Yes. Yep. And we can do both at the same time if needed.
What got you into this?
I love medicine. I love surgery. I have a passion for what I do. And I think that plastic surgery is a great combination of combining the medicine aspect as well as the creative aspect. And so that's why plastic surgery, I feel like, is perfect.
And when did you decide to get into plastic surgery? And I'm talking about when you were young. I mean, you did admit that when you were under the age of 10, you knew you wanted to be a doctor.
Correct. So I think it was about 7 years old when I first said to my parents that I'm going to be a doctor. And At that time, I don't know how serious they took me, but I knew that, I was going to become a doctor one day. And so, I worked the majority of my life to get there. It wasn't until med school when my path kind of took me towards plastic surgery. My first choice was actually orthopedic surgery. I'd spent a lot of time with orthopedic surgeons. I was very active as a kid. I did a lot of sports. So sports medicine, orthopedic surgery was, I felt like at the time, a little more natural of a fit. But once I learned about plastic surgery, I knew that that was the path for me.
Share with us a story of one of your patients.
One of my most memorable stories was one of my very early cases I did in my career. And she was pretty young. She was in her 30s and unfortunately was diagnosed with breast cancer. She had a history of breast cancer in her family. And so we started, and at that age, it's exceedingly difficult to sort of wrap your head around not only having cancer, but removing your breast. And so it obviously took a lot more time in the consult to talk to her, sort of make her feel comfortable. And she wasn't sure if she wanted to go through with breast reconstruction. So we met again for a consult, and she decided to go through with it. And she actually ended up being so happy with the result. She thought it to her and to me, it almost looked like a breast augmentation, like a cosmetic surgery, that it ended up looking so good that she ended up, because of her risk, having a mastectomy on the other side and having a breast implant on the other side. And, it's one of those things where, I come into the room and the patient's tearful. You don't know if it's a bad tears or a good tears, and it ended up being a good tears. And so that was, a case that I still remember. And that's one of the big reasons why I, continue to do this type of surgery.
How soon after an operation do the bandages get removed and they get to see your results?
So I keep everything on for a week, and generally the patients can take a look at the results after a week. I try to not have patients pay too much attention for the first month because there is a lot of swelling and things can change. But generally you can see the results after the first week, and that's about how long it takes.
And what can you tell people who have breast cancer about the fact that they can be fine afterwards with your work?
I try to give them options, and, I show them before and after photos, and I let them know that, this is sort of a journey. I try to make them feel comfortable, obviously while setting realistic expectations. But like you mentioned, the technology's advanced, the surgical techniques have advanced, and now we're able to get breast reconstruction results that look very similar to breast augmentations and have really great cosmetic outcomes.
Thank you, Dr. Brandon Richland, for sharing your insights on Impact OC. And I thank everyone for tuning in. I'm OC Talk Radio Public Affairs Director Dawn Camber. Have an impactful day.
You've been listening to Impact OC, the only program showcasing the people and organizations shaping our community. Right here on Orange County's only community radio station, OC Talk Radio.